Today, we're fortunate to have Dr. Amanda Kong, Associate Professor, Chief of the Section of Breast Surgery, who comes from us from the Medical College of Wisconsin. Dr. Kong completed her Doctorate of Medicine at Warren Alford Medical School of Brown University in Rhode Island. She completed her general surgery internship and residency at Mount Sinai School of Medicine in New York, and her fellowship was in breast surgical oncology at MD Anderson Cancer Center in Houston, Texas. And Dr. Kong is certified in general surgery, and we're so blessed to have Dr. Kong speaking today. Thank you.
Thanks very much. Can you guys hear me? Okay. If you can't hear me, just let me know. Thank you so much for having me today. I have worked with a couple of people here from afar, Dr. Lundberg and Dr. Vanderkleef, and I have shared patients for many years. And I like to sometimes call us like Facebook friends. So Dr. Vanderkleef and I have talked on the phone and corresponded many times, and it was so nice to finally meet him in person and to come up to Fond du Lac. And Dr. Raffke, I remember she and I worked together when she was a resident at CME. So thanks very much. I'm going to cover a lot of information today, so hopefully you'll have a chance to review the slides. It's a very large topic. I gave this similar talk for the state conference for the family medicine refresher course that they have every year down in Milwaukee for that group. And so I think you'll find it interesting. At the end, I'll cover some cases of patients that I've treated. And there's a lot of detail and a lot of heavy-hitting stuff, but the point of it is not so much for you to learn all the specifics. So for primary care physicians, you're not going to be giving the chemo or the radiation or doing the surgery, but just to show you how far we've come in the treatment of breast cancer patients. And feel free to interrupt me anytime if you have any questions. We're going to go over some risk factors, some screening and imaging, and then I'm going to talk a little bit about treatment through the cases. I'll spend a little more time on the first two because I think as primary care physicians, that's really the front line. It's and the people who actually diagnose the patients and send them to us. I have no disclosures. So if we look at cancer in women in general, breast cancer is actually the most commonly diagnosed cancer in women. There are about 230,000 cases a year, but it's actually only the second leading cause of cancer death. It's lung cancer that actually is the number one cause of death in women. There's about 40,000 deaths from breast cancer a year. Oftentimes in my office, I will be counseling patients. I feel like a primary care physician because I'm talking to people about not smoking so much. But if we look specifically at the state of Wisconsin, there are about 5,000 cancers diagnosed each year and about 750 deaths. The good news is that the mortality is actually decreasing from breast cancer, although we see an increased incidence. And really the reason for that is because we have improved methods of detection. So some of you have heard of 3D mammography. So we'll talk a little bit about that, and I'll get into some more imaging later. But we can see that over time, mortality from breast cancer on the left is decreasing in the United States. And data from the National Cancer Institute shows us that the 10-year mortality is also going in the same direction. So let's talk about some of the risk factors for breast cancer. So the first risk factor is obviously age. So the older you get, the more likely your DNA is unable to repair itself, the more likely you're going to develop breast cancer. And if you get that famous number of 12% lifetime risk of developing breast cancer, or 1 in 8 women. There are other non-modifiable risk factors besides age. Obviously, sex. Women are more likely to have breast cancer than men, although those of you who have been following the news saw that Beyonce's father just announced that he had male breast cancer. So I've treated several patients, and oftentimes male breast cancer is missed. But stage for stage, they have the same survival as women. A family history, if you had high-risk lesions in your breast, if you have radiation exposure, so patients who have had Hodgkin's lymphoma and prior radiation are at risk. I've even had patients who are radiated for acne on their chest wall many, many years ago, who have also been at risk for breast cancer. And then reproductive factors, so how much estrogen is coursing through your body, when did you start your period, how many pregnancies, and when you stopped having your period. So a lot of times I'll see patients, they'll come in on hormone replacement therapy, and I think when, everyone knows we're moving away from weaning people on the HRT for many, many years. It has some benefits for both cardiac health and decreasing hot flashes, but we know that there's an increase of risk of breast cancer with giving HRT. So we know that with more than 5 years of duration, this increases your risk by 30 to 45%, and if you're a current user, there's increased risk with the combo pills versus estrogen alone. And since 2002, when we sort of talked about this risk with HRT and saw a decline in use, the number of breast cancers have declined. So I saw a woman in my office not too long ago. She had been on HRT for 20 years, and she told me she didn't regret it. She was 70 and she looked like she was 50, but she also had bilateral breast cancer. I don't know how many of you have had patients tell you they're on bioidentical hormones. Have any of you heard of those? Yeah. So I've had, they were marketed as natural hormones. There's a pharmacy in Madison that produces them. Oprah was touting them on her show. They act in a similar fashion to estrogen and progesterone. There's no data confirming their safety. They should be treated similarly as HRT. You should lay patients on them for a long time. I actually encourage patients, there's an endocrinologist I work with, if they're on these bioidentical hormones, because a lot of times because they're not regulated, you don't know what's in them. And so I have them see there's a female endocrinologist that's great who works with me to kind of test their levels and see if they really didn't need them at all. Patients will say, well, I need this, fill in the blank. When you look at their hormone levels, they're normal. Some people have associated breast cancer with coffee. There's an update from the Women's Health Initiative. There's actually no risk in women who drank 4 or more cups of coffee a day. So for those of you who are caffeine addicts, that's great. There might be a link between coffee and benign breast disease. We often tell people when you have breast pain, decrease your caffeine intake, but there's really no link with coffee. So alcohol, this is a really big thing that we tell our patients. So it does increase your circulating levels of estrogen, and studies have linked an increased risk of breast cancer to shrink. And that's highest in postmenopausal women. So in 2017, the American Society of Clinical Oncology actually released a consensus statement that that alcohol intake increases the risk of head, neck, colon, breast, and prostate cancer. They did not say exactly how much, quantify how much or how often. So when patients ask me, I tell them, hey, look, here's the information. You're a grown person. You can make your decision whether you want to or not. Some of our oncologists are very, very strict, and then they come see me and they're crawling off the wall. Can I have 1 glass of wine, please? And I say, you can have a glass of wine. You have to live your life and enjoy it as well. Food choices. So there's no definitive studies establishing the benefit or harm of certain foods. So patients always will ask me, if I eat meat, if I eat, should I only eat organic? Should I not eat sugar in my diet? Should I not eat soy? Probably the most common one I get is, should I not eat soy products? And because they're phytoestrogens in soy. So that's an interesting question. So I tell them, well, let's look at the Asian population. They have the lowest risk of breast cancer, and they eat probably 10 times more soy than anyone does in the United States, so it's actually safe. However, soy as a supplement is not safe. So there used to be a woman who wrote an excellent column in the ASCO Post. The American Society of Clinical Oncology had this throwaway newspaper, and she doesn't do it anymore, but she was a PhD at Memorial Sloan Kettering, and she wrote this article about soy. So every time the Post came out, she would choose a different supplement, like turmeric or whatnot. And if you take soy as a supplement, which I wasn't aware it existed, that will increase your risk. But if you eat it as a natural food product, it will not increase your risk. There's, for those of you who are app junkies on your phone, there's one called, I think it's called About Herbs. I can check on my phone afterwards. It's absolutely free. It's from Memorial Sloan Kettering. And so if you have a patient that's on any weird supplement, you can just put it in, and then it has a tab for patients, and it has a tab for physicians, and it tells you what drugs it interacts with. So even beyond a cancer standpoint, it'll tell you, you can't take Coumadin with it or whatever, and it'll tell you the evidence-based data about whether it's good or not. So I highly recommend downloading that on your phone. Obesity, we know for a long time, has been a risk factor for not just breast cancer, but any cancer. Unlikely causes of cancer that people have brought up. So use of hair dyes, cell phones, antiperspirant. I'm sure a lot of you have heard of, oh, I'm not going to use deodorant anymore because it increases your risk of breast cancer. There's really no data to support that. I can tell you my mother was the worldwide product safety director for Colgate-Palmolive, which also owns Menin deodorant. And so, I've had this discussion with her. It's really safe. Again, soy, water bottles, all those things. So let's talk a little bit now about screening and imaging. So the goal of screening is to detect as many cancers as possible without harming people. And if we detect cancers before they can be felt at an earlier stage, we're more likely to be curable. And that's why I think we're seeing that decreasing mortality because we're catching cancers earlier. So I got this slide from my colleague, who's the chief of breast imaging, because I thought it was really interesting. So if you screen 1,000 women, about 100 of them will be recalled. And of the 100 that are recalled, about 10 to 20 will end up getting some sort of percutaneous biopsy. Now those 10 to 20 biopsies, about 3 to 5 will ultimately yield cancers. So what's the difference between a screening and a diagnostic mammogram? I'm not sure how it works here in Fond du Lac, but when we have a patient who, a primary care doctor will order a screen test, and if there's something abnormal, so these are women who get screened, the women who are getting screening tests are the average women, they have no complaints. Where we are, you actually don't need a doctor, you can just show up and get a screening mammogram. And they're usually performed and interpreted in a batch. So we have every day an attending is the screening attending. They sit in this room and they just read like nonstop, and so they're not interrupted. If the patient has an abnormality on their screen, then they need a diagnostic. Or if they show up to your office and they're complaining that they have some sort of problem, nipple discharge, breast pain, a mass, then you should automatically go to diagnostic. So that's when there's some sort of clinical concern. Again, a lump, skin changes, nipple retraction, bloody nipple discharge, focal pain. Anyone who had a screening mammogram previously, they said, oh, you need short-term follow-up. This one, we will call our primary care doctors and say, hey, look, Mrs. Jones had an abnormal screening mammogram. Please put the order in for the diagnostic. And then the report will go to the doctor. Usually, where we are, if you have a diagnostic, if the radiologist on site will look it up automatically and give the patient the results immediately. And I think that's pretty standard in most places. So when you get a diagnostic mammogram versus an ultrasound, so women who are 30 years and older always get a mammogram first, and this is the American College of Radiology, and a focused ultrasound if indicated. If a woman is less than 30, they should get a focused ultrasound first. And that makes sense because it's, in general, women less than 30 are less likely to have cancer, and it's most likely to be a benign mass that can be diagnosed on ultrasound. So annual screening mammography is recommended starting at age 40 for the general population. Now, I know that's a controversial statement. It depends on who you ask, right? So if you ask the United States Preventative Task Force, they're going to tell you to start screening at 50. If you ask the American College of Radiology, they tell you to start screening at 40. If you ask the American Cancer Society, they straddle the midline. They say have a discussion from 40 to 45, 45 to 50, consider screening yearly. I think that it depends on where you're coming from. For us in the breast center, we still hold true to the American College of Radiology, and we do yearly starting at age 40. If you have a BRCA carrier or so a known BRCA carrier or a relative of a BRCA carrier who doesn't want to get tested, we start at age 25 to 30. If there's a first-degree relative who had breast cancer, we usually screen 10 years earlier, not earlier than 25. Or if someone has a lifetime risk of breast cancer that's greater than 20%. So there's different risk calculators you can use. Probably the easiest one is the GAIL model. You can just type GAIL model, G-A-I-L, into Google and it'll come up. It's the National Cancer Institute. There's about 10 questions you can plug in for your patients, and it will give them their 5-year and their lifetime risk of developing breast cancer. This is for patients who do not have a diagnosis of cancer, but people who you just want to, who have a family history who have had maybe an abnormal breast biopsy. And for women, if you have any patients who had a history of lymphoma when they were younger, you want to start screening 8 years after their radiation, but not before 25. So if you have a woman who's high risk, and I'll tell you, we'll go over who they are. You want to do a mammogram and an MRI every year starting at age 30. And when we say every year, we alternate them. So if you get a mammogram in January, you're going to get an MRI in June, so they're offset a little bit. These are people who are BRCA carriers, people who are family relatives, who are untested of a known BRCA carrier, people who have had radiation, other genetic abnormalities which are rare, like Nephromy and Cowden syndrome, or give a lifetime risk greater than 20% based on like the Gale model, for example. So let's talk about how many of you here have heard of 3D mammography. Right? So, when 3D mammography came out, it was interesting. I asked my colleague, well, how exactly does it work? And I'm going to show you it's how to explain it to patients when they ask about, well, should I get 3D mammography and why is it better? So the first question I usually get about mammography in general is I'm afraid of getting too much radiation. So 3D mammography is a little bit more radiation than a 2D. A 2D mammogram, the amount of radiation you get from that is the same radiation you get flying from New York to LA on a plane flight or walking around New York City or Boston for a day. And I actually had to look that up because when I first moved here, my boss called me up, the chairman of the surgery, and he said, hey, I signed us up for a radio show on NPR. We have to talk about all sorts of screening. So it's really not that much radiation. So 3D mammography, again, it exists for both screening and for diagnostic. It's the same breast positioning and standard compression you would do for any other mammogram. And what it does is it acquires images at several different angles in a short amount of time, and they reconstruct the images into these high-resolution slices. So, sometimes you can have overlapping tissue that may look like something, and this takes care of that. So, here we go. So if you look at the one on the left, 2D imaging, if you have the star and the circle, 2D imaging just takes one view, and so you won't see the circle because it's being hidden by the star. But if you look at 3D imaging, it basically comes at 3 different angles. And you can see that if you're taking at 3 different angles, you'll see different parts of the circle at times, so then you know that it exists. And so 3D mammography basically increases your detection rate and it increases your false positive rate. So, for example, on the left, here's an area of the breast that's like from 2D mammography, and it looks like just some dense breast tissue. It's not very exciting. But the same area taken with 3D imaging, if you look on the right, you can see a spiculated mass there. That's clearly a cancer. So here's what some things look like on mammography. So here's a mass may typically look like. Calcification. So calcifications can be benign or they can be malignant. And so I tell patients, well, I have calcifications. My friend had them. She had cancer. I don't. We see them with increasing age, especially you'll see more calcifications lining blood vessels. So we'll see vascular calcifications, like this patient actually has some right up here. And so if their calcifications are clustered and they're irregular looking, they're more likely to be malignant rather than sporadic and smooth and round. When we get ultrasounds of tumors, they're often very irregularly shaped like this. They're often taller than wide. And the last method of imaging the breast is the MRI. And so, this has become over the past 10 years I've been practicing, it's becoming more and more common to get MRI. So we actually, we don't get MRIs on everyone, and I'll get to that in a second, but it's very, very sensitive. So it picks up a lot of different things, but it's not very specific. So you do have a false positive rate. It looks at the morphology and enhancement of the tissue with gadolinium, and you use it for screening in certain populations like we talked about before, those high-risk patients. So very quickly, there was a controversy about using gadolinium. So your patients may ask you about this because people are getting more and more internet savvy. So I just seen that a patient who said, I don't want gadolinium, I don't want contrast, like I heard that it can stay in you. So there was a study that was done in Japan. It was they did autopsies on people who had MRIs, and they found gadolinium was collecting in the brainstem, but they didn't know why it was doing that, and they didn't know if there was an effect from that. Those people had passed away for various reasons. This was a big topic at the radiology conference, and the Mayo Clinic had replicated it and found the same thing. the magic number seems to be around 5, but now we use a contrast called Gatavist. Doesn't cross the blood-brain barrier, images the breast obviously. If you're going to be doing a brain MRI, but it is quite good. So when do we order it? So we order it if there's discordant imaging findings. So if something looks benign, it looks malignant biopsy, it's benign, but it looks nice, we may get an MRI. In axillary cancer with no obvious breast primary, I saw a patient recently, she had a huge mass in her axilla, and biopsy-proven breast cancer, but nothing on mammography on her breast, so she's actually getting her MRI-guided biopsy today. Sometimes we get it for extensive disease workup. I don't get it in all patients. I usually get it in patients with invasive lobular cancer because invasive lobular tends not to show up as well on mammogram and ultrasound. And people with implants, so the FDA has just recently released that if you have silicone implants, you should get them imaged with MRI every 3 years to make sure that their integrity is not breached. So I always laugh at this picture because it looks like this woman's going to the spa to get her MRI, but truthfully, 9 out of 10 patients, I actually have to give them Valium or Ativan to make it through the tube. I don't know if any of you have had an MRI before. I've had one on my ankle, and I couldn't, that's not even like laying there on my breast, and it's very loud and it's uncomfortable, so imagine like laying like this and being stuck in a tube. One brief line about genetics. So a lot of patients come in and they say, oh, I must, like, does everyone in my family have to get tested? This must be genetic. And I always remind them that actually only 10% of breast cancer is actually genetic, 90% is actually sporadic. And so the most common one we think about is BRCA1, BRCA2, and that's where we see ovarian and breast in the family. We are now, when I started my practice, we used to have 5 gene panels. Now we're sending 30 to 60 genes on a routine basis. We'll send off the quick panel, which I like to call the quick panel. That's usually back in about 7 to 10 days, and we use that for surgical decision because those are the high-risk genes. So, BRCA1, BRCA2, P53, CHEK2. So we'll get those. Those usually yield at least 20% lifetime risk. And then the other 30 to 60, most of which we don't know what they do, we'll send off, and that takes about a month later. We also have a new clinic at MCW that if you have, for example, say you have Lee-Fraumeni syndrome and you're at risk for, tons of cancer, we have a clinic where patients who have those kind of gene mutations will be, they'll keep track of all their screening for all the different cancers they're at risk for. Because as our genetics improves, that is a problem. So just a brief word about staging. We went from AJCC 7th edition to 8th edition. The 7th edition was very easy for most of us. We knew, if you knew the size of the tumor, the node status, whether it was metastases, in our head, we could quickly calculate and say it's stage 1, 2, 3, whatnot. And now it's increasingly complicated. It's taking other things into account, like genomic testing or estrogen receptors or HER2. And even I can't, none of my colleagues, we can't memorize anything. So either you can look it up in the staging manual, or we have it actually built into our Epic because it's gotten so complicated, or you can just purchase the TNM app, 8th edition, which my partner just told me about. He is more savvy than me with technology because he's about 10 years younger. And so I just plug that in and let it calculate it for me. So now I'm going to tell you, this is the part where it's going to get really complicated. And again, it's not meant for like the primary care patient to kind of know all of this, but I just wanted to show you and showcase how far things have come in surgery. So, or in breast cancer treatment. So I always say breast cancer treatment is a team sport. You need to have a surgeon, a radiologist, a radiation oncologist, and a medical oncologist, and we have to work together as a cohesive team to provide patients really the best survival. And that's the basic core, but there's so many people that are involved in taking care of a patient. So here's case 1, and how tumor genetics have now shaped our treatment. So this was a 59-year-old female who was found to have an abnormality in her left breast on a routine screening mammogram. She started period at 12, she went through menopause at 42, and took oral contraceptives for 3 years. Her brother had esophageal cancer at 64. She had a great niece with leukemia, and an aunt with breast cancer in her 60s. When I met her on exam, she had a biopsy site at 1 o'clock. She had no palpable lymph nodes. I mean, it was really an unremarkable exam. And the diagnosis she came to me with was that she had an invasive ductal carcinoma grade 1, ERP or positive, HER2 negative. This is a very typical patient. And as you can see here, it's this tiny little cancer, right? And her breast is nice and fatty. It's really easy to read her mammogram, and it really sticks out right there. So this is typically a patient I would not get an MRI on. So we took her to the multidisciplinary tumor board. We did surgery up front. I did a lumpectomy and a sentinel node biopsy to make sure that cancer hadn't spread to her armpit. And our pathology came back as a 7 millimeter grade 1 invasive ductal carcinoma. I took 4 sentinel nodes out. So for those of you who are not familiar with that procedure, we inject a dye beneath the nipple. It spreads to the armpit. I make a small cut in the armpit. I take out the lymph nodes and pick up the dye. The thought is that cancer spreads like beads on a string. If it goes the first few, then that likelihood that other ones are positive is higher than if nothing goes to the first few. So one had a macromet, so it had a big chunk of tumor, and then one with a micromet, so it was less than 2 millimeters. And there was no TB, so the margins were all negative. So we were very surprised that, with a 7 millimeter grade 1 tumor, that she actually had 2 lymph nodes that were positive. So the first question was, well, when I first started my practice, if someone had a positive lymph node, we said, well, the horse is out of the barn, you gotta clear the field. And we used to take out everyone's lymph nodes, right? So the biggest risk when you take out everyone's lymph nodes is number one that everyone fears is lymphedema. I mean, it's very life-changing and can be very debilitating. So we no longer do that anymore. So there was a study called the Z11 trial. It was a multi-center randomized phase 3 trial, and they looked at women who had invasive breast cancer that was less than 5 centimeters, didn't feel anything in their armpit to begin with, and they had a positive node intraoperatively. And what they did was they randomized them to the standard of the care at the time, which was taking them all out, or just doing nothing, just closing them up and saying, hey, we're done. The important thing to know about the women in this trial was that they all received some sort of systemic therapy, whether it was chemotherapy or anti-endocrine therapy. And the vast majority of them received radiation, because when you have a lumpectomy, we always give radiation. And so the interesting thing you would say is, okay, so you leave half the group. You're leaving them with this positive disease in the armpit that you knew about. So, what happens to these patients? So they actually published the 10-year data, and they found out the survival in the axillary lymph node group, that's like taking all the lymph nodes out, was 83.6%. And actually, in the group where they just took out the few and then closed them up, the survival was 86%. The disease-free survival, again, it was actually higher, believe it or not, in that group where they just took out a few. And then what about tumor coming back in the armpit? Well, if you see, it's actually higher in the group that got all their lymph nodes out, it's 6.2%, than in the group that had just a few. So really, we don't do any lymph node, we don't do a completion axillary dissection on everyone anymore. And so people have a better quality of life, and one of the things they found in that study was the rates of lymphedema were obviously much lower than people who didn't have the whole dissection. So we actually then she went to the medical oncologist, and she had something called Oncotype DX done. So her tumor was sent for a recurrence score, which I'm going to talk about in a second, and it was 13. She got radiation, and then we started her on a pill. So in the old days, like if you had a positive lymph node, the thought was, well, then you obviously need chemotherapy. It's not all over your body. So Oncotype DX is a 21-gene assay developed for ER-positive tumors that are lymph node negative. All the sentinel work was done by Dr. Pink, who's a pathologist. And they did this large validation trial, and they found that this score, based on this assay, was able to predict distant recurrence. So that means going to places like your bones or your lungs or your liver better than just looking at the tumor characteristics and like having a gestalt about whether it would spread or not. And so they found that this recurrence score was a really good predictor. So if you have a low score, you're likely not to recur. If you have a high score, you're very likely to recur. And so therefore, those people with high score, they went on to do a study and found that if you give them chemotherapy, they actually live longer. So we use this test to help us decide whether we give chemotherapy or not. So what about women with with node-positive cancer? So this lady, she was postmenopausal. Remember, she had a positive node. She had this tiny little tumor. Do we really want to be giving her chemotherapy? So this is the previous trial was all the trials were done prospectively. This was a retrospective study. Again, it's complicated. I was looking at different groups of chemotherapy and types of chemotherapy in cancer patients. But the interesting thing was, in these patients that had positive lymph nodes, they did this oncotype score as well, even though the test wasn't developed for people with positive scores. And the bottom line was that this work was actually done in Chicago by a well-known oncologist, was that even in patients who are node positive, this score held true in terms of survival. So sometimes when we have an older woman who has node positive disease, like 1 or 2 positive lymph nodes, and we're not really super excited about giving her chemotherapy, we'll sometimes apply this score as well. Again, the data is not as strong because it's retrospective, but we still will use it. And then again, with a high recurrence score, they found that women who had positives really had a benefit to receiving chemotherapy. So this is when people talk about tailored or personalized medicine. These are some of the tests that we order now to help us make that decision. So here's case number 2. So this was a 56-year-old lady. She had a left abnormality of a screening mammogram. She started her period at 13. She underwent surgical menopause at 48, and then an estrogen patch for 5 years after that. 2 pregnancies, 2 live births. She had a maternal aunt with bilateral breast cancer in her 40s, a maternal cousin with breast cancer at an unknown age, and a maternal aunt with ovarian cancer at 82. So on exam, she had a vaguely palpable, non-discrete mass, like 2 to 3 centimeter area at 9 o'clock, and I didn't palpate any lymph nodes. Her biopsy that she came with was invasive ductal carcinoma grade 3. She was ER/PR positive, and she was HER2 amplified. So that's one of the receptors that we check tumors for. And in general, you want to be ER/PR positive. You do not want to be HER2 amplified. So I actually obtained an MRI on her, and as you can see, when we look at an MRI, it looks like they're standing at the foot of the patient. So the right breast is here, the left breast is here, and you can see she has a really ugly looking tumor there. So we took her to the multidisciplinary conference, and we decided to give her neoadjuvant chemotherapy. She underwent genetic testing, which was ultimately negative, and at the time we staged her with a stage 2 breast cancer. So after we gave her chemotherapy, we got a repeat MRI, and you can see it's completely gone. Despite it being completely gone, she opted for a total mastectomy and a sentinel lymph biopsy, although I would have said that she's definitely a candidate for having a lumpectomy given the fact that nothing was left. And when we got her specimen back, her pathology report, it said she had a complete pathologic response. There was no cancer left whatsoever. So she then went on to continue Herceptin for a year and tamoxifen. So Herceptin is trastuzumab. We're going to talk about that. It's actually a monoclonal antibody against HER2. And so there was a landmark trial called the HERA trial, and it looked at, just observing people versus giving them trastuzumab for an entire year. And they found that in the group that got trastuzumab for a year, there was actually a survival benefit. So you may see patients, breast cancer patients of yours, who they say they finished their chemotherapy, but they're still getting therapy, and you're not really sure what that is. It's probably trastuzumab. And we're starting to give another drug called pertuzumab, which we'll talk about in a little bit. Trastuzumab, basically, most patients don't have many side effects to it. It is tolerated very well. Pertuzumab, which is given in conjunction with trastuzumab these days, causes a lot of diarrhea. But there was really giving the trastuzumab for a year, there's an actual benefit in disease-free survival of 84%. And so, the one thing about trastuzumab is that it can have cardiotoxic effects. So one of the drugs we give it with is adriamycin. So adriamycin also causes heart failure, and up to 10% of people, they can develop permanent heart damage. one of the patients that sticks out in my mind is I have a 45-year-old woman in my practice who, she's an avid biker. She bikes like 60 miles a week, whatever. She underwent treatment with adriamycin, and a year after her completion of all her treatment, she came to my office and follow-up. And she was really tough. She was tachycardic. She was maybe 110. And she's a she's a pastor, and she's very low key. And I said to her, your heart's racing. Like, are you nervous? She's like, no, I feel fine. She said, well, I have a history of SVT, supraventricular tachycardia. And I said, you know what? Something just doesn't seem right. Like, you shouldn't be walking around with a heart rate of 110. Do me a favor, go to your primary care doctor. Please get this worked up. And so I was worried enough to the next day, I called her and she's like, I made an appointment, I'm gonna see my primary care doctor today. So her primary care doctor then went, she got an EKG and sort of sinus tachycardia, and she ordered a bunch of labs, and they were cooking. In the meantime, it was a Friday, she went on a bike ride. She went on a 30-mile bike ride with her friends. And when she got back, she was so tired that her friends took her to the emergency room. They're like, this is not you. This is not normal. You shouldn't be this tired. And I don't know if this was down in because Racine Kenosha area. I don't know what prompted them, but they got an echo on her. Her ejection fraction was 14%. Yeah, so she called me and said, hey, I was admitted to the hospital. You were right, something was wrong with me. My ejection fraction was 14%, which now explains why she was tachycardic. And so I hooked her up with the advanced heart failure team up in Milwaukee. And so she's been slowly recovering. So adriamycin usually can cause permanent heart damage. Trastuzumab is usually reversible. There's two different mechanisms. So in this study, they looked at, well, what's the cardiotoxicity, looking at these different regimens. Oncologists are always trying to figure out what's the best regimen to give. And they ultimately decided that TCH, that's one of the regimens that we give, had less cardiotoxicity and was beneficial for disease-free survival. So that's one of the ones we do give. I did mention that there was another drug called pertuzumab. Again, it's another crazy study. They were looking at what happens if we add this other drug now called pertuzumab to trastuzumab. And their primary endpoint was looking at this pathologic complete response. So if we add this other drug, can we make more of the cancer go away? And so when patients always ask me, why do we do chemo up front? I say, for many years we always did surgery, chemo, radiation, whatever. And then you hear that, you always hear about a patient who, well, they recurred within a year and they died. Or you hear about a patient who lived till they were 90, they broke their hip and they died. And we don't know, did the chemo really work? Well, probably in that 90-year-old, their tumor is very sensitive to the chemo. That's why it never occurred. And the person who's, who recurred a year later, their tumor was resistant to the chemotherapy. And so if you don't know until the shoe drops, right, whether it works or not, if you give the chemotherapy up front while the tumor is in, you know if it's effective or not. And that's why a lot of our advances in oncology are giving patients chemotherapy up front, so we know it works or not. I remember Dr. Lundberg and I shared a patient, we were just talking about it earlier, she was in her 20s, it was one of the most horrific cases he and I have had, where we just kept giving her therapy after therapy, Dr. Lundberg did, and she just never responded to anything. That did not end very well. So when this new drug became available, and they looked at all these combinations, they found that if you gave it together, the pathologic complete response rates were really, really high. You can see in the numbers here, we're seeing rates of up to 63%. If you look all the way here, meaning these patients had 63% of the time the tumor completely went away with that combination. So we will often give pertuzumab with trastuzumab now. And the same, so then people said, well, is it safe to be giving all this cardiotoxic treatment to patients? And the bottom line from this next study they did was that trastuzumab and pertuzumab are well tolerated, both from a heart standpoint, and there was no additional cardiac dysfunction. I will say though that pertuzumab, and Dr. Lundberg can probably speak more to this, does really cause this unremitting diarrhea in patients, so it's hard to tolerate. but amazingly, we're seeing these pathologic complete response rates of 57, 66%. And I don't think, in any other drug, in any other cancer, you're going to see response rates that high. So in summary, risk factors, some are modifiable, like weight, alcohol, HRT. I'll tell patients to stop taking HRT. We talk about exercise programs, reducing their I don't expect people to say none, but if they're drinking every night, I say, can we cut it down to 3 times a week? Some things are not modifiable. Your genetics, your age. Screening is still the best method of detection. We are actually going to only 3D mammograms starting, I think, in 2020, unless a patient requested 2D, everyone's be getting a 3D mammogram at our institution. In terms of the field of surgery, less is more. We're doing less surgery without any changes in survival, so we're not operating in the armpit as much, and it's leading ultimately to better patient satisfaction and quality of life. And bottom line, breast cancer is a systemic disease, so everyone thinks it's surgery. Like if I remove both my breasts, I'll live longer, but it's really not the surgeon. And I tell many of my patients now that, I've learned after all this time that I'm not the most important part of your team. It's really the medical oncologist who's going to give you the treatments that are going to keep you alive and well and into the future. So thank you very much. If you have any questions.